Well, welcome to the Young Dementia Network webinar. This one is a collaboration, as you can see, between the Netherlands Young Onset Dementia Centre and the Young Dementia Network. I'm Tessa Guttridge, Chair of the Young Dementia Network, and it's my pleasure to welcome Jackie and Romana and Harrow, who we're going to introduce you to a little later. First of all, also to say that Jan Papma, who was originally going to be presenting to you, is unwell, and so, but we're very fortunate for Jackie to be taking her place. Reminder that you're not on video or audio, but we very much like you to put your questions into the Q&A function, and we will protect some time at the end to respond to them. And of course, do use the chat. That would be great. But first off, we're going to see a short film of Catherine in conversation with a family member of a person with young onset dementia who was recently diagnosed in his mid-50s. Catherine's going to run the film now.
I'm delighted to be joined here by a family member who supports their partner following their recent diagnosis of young onset dementia. They've asked us today to keep them anonymous, but are really keen to share their experiences of the diagnosis process and what they went through. So thank you very much for joining me today. We really appreciate you being here.
Pleasure.
During this webinar, we're going to be discussing the importance of support during the young onset dementia diagnosis process, from the time of referral through to the time the diagnosis was made. What support and information did you receive during this time?
I would say very little. Not much information coming from the GP that we initially met. Very little afterwards when we had our initial chats with the neurologist. And there was lots of information, of course, available, but that was something I sought myself. And when the diagnosis was delivered, very, very minimal support at that time and immediately afterwards.
Yeah, and then at that point, you had to seek out some support yourself?
I did. I already was aware that we have a local support organization for specifically early onset dementia. Just through my own Googling and research, the consultant mentioned the same group and offered to make a referral. So we both did that.
Yeah. And following that initial contact with the young onset dementia support advisors, what support did you get from at that point after that?
It was like night and day. It really felt like somebody was engaged with our situation, knew what we were going through, and that there was a vast amount of support available. And now I knew how to get that if I needed to. So there was the initial phone call with one of the advisors, which lasted a good hour and a half. And I remember apologizing that I took so much of their time, and they said they always do this for the first contact. Yeah. Then the same person came to visit us at home and made it very, very clear that they were there to support us. Something that was very helpful, and they also did, was put me in touch with other family members, and that peer support was crucial.
Yeah, that sounds what you needed at that time. It was important to have that.
Yeah.
So how important do you think it is to have support that's tailored to your individual and family circumstances, both during and immediately after the assessment and diagnosis?
I think it's extremely important because it's certain things are the same, but otherwise everybody is sorry about the cliche, but the journey is different, and there's so many different ways people react. Typically, the patient reacts in one way, and then those supporting them in their own way, and it takes a special skill to be able to offer that kind of support.
Yeah. So what improvements would you like to see in terms of the experience of diagnosis for people with young onset dementia?
Well, it would be very, very helpful to have somebody there in just that supporting role. Um, I would say in our case, the consultant was, very kind and had a decent bedside manner, but clearly that was not what their strengths were or what they were interested in doing. They approached this as a researcher, I would say, more than anything. And we could have really used somebody there, on site with us, just helping through the initial shock.
Yeah.
And I think after that, it would have been good for somebody to reach out to us, and more than once, just kind of because it's very hard to process all the information there at once when you have this life-changing diagnosis given to you, and there's so many things that need to be done. So I think it would be good for somebody actively to call, make sure the patient is okay, the family members are okay, what kind of things they need. So it's not terribly helpful to be giving a long list of things that need to be done there and then. I think my questions, I knew already quite a bit, much more than my husband did, of what was going on, but still in that moment of getting the diagnosis and your fears confirmed, I think my questions to this medical professional were more like, what do I tell to my children? When do I tell them? How are they going to react? How are I going to survive without my partner's salary? Things like that. And of course, it's not their job to offer that kind of support, but that's really what you need, very practical. And then you need somebody to tell you, are your wills in order? Do you have the lasting power attorney? But this should come as piecemeal, not all at once, and not just here is a website, go and do your homework. It works for some people. I like to be very informed, and I'm fairly good at doing the research and finding my peer support and so forth, but a lot of people are not, and they should not be left alone.
Yeah, so having that person to talk to in that time is what you need, that contact.
So essential, yes. Yeah.
Well, thank you very much. Thank you for sharing your experience today. We really appreciate your thoughts and your experience on what you went through with your partner's diagnosis. So thank you very much.
Thank you to you, and thank you for the work you're doing.
Thank you.
So it's really impactful, isn't it, hearing the reality of somebody's personal experience. And I noted support is the difference between night and day, and that really made a mark with me. I think and the call for specialist skills and that importance of tailoring. Anyway, let me hand over to Jackie now, who's going to offer her presentation. Thank you, Jackie.
Good afternoon, everyone. Thank you, Tessa. And I would also like to thank the person in the video for sharing their experiences today with us. My name is Jackie Poos. I'm a postdoctoral researcher at the Alzheimer's Center Erasmus MC in Rotterdam, the Netherlands. And just to offer a brief sketch of what that center is and does, it is one of 5 Alzheimer's centers in the Netherlands, where we perform high quality care for dementia, but also scientific research and education. And of course, we collaborate closely with each other, but also with other institutions working on dementia. And we are actually specialized in the rarer forms of dementia, including young onset dementia, and acknowledged an expertise center for frontotemporal dementia by the Dutch Ministry of Health. So a lot of the research that we do is focused on young onset dementia and FTD in particular. And today I would like to talk about how we can bridge the gap from diagnosis to post-diagnostic support. So how we can support people with young onset dementia and their families during the diagnostic trajectory. So this is an overview of what I would like to talk about today. I would like to start with identifying the current gaps. So what can we learn from the literature on young onset dementias and studies that have been performed? And also the availability, so looking at the availability of support, so what is out there across Europe and even beyond, and also zooming in on studies reporting the lived experiences of people with young onset dementia and their families. So really an overview of the literature, and then moving on to what we are actually doing at the Alzheimer's Center Erasmus MC to fill this gap, or at least try to fill this gap. So we set up a program on post-diagnostic care, and I would like to share some of the preliminary results of that, as well as the framework specifically for young onset dementia that we are currently developing. So already going back quite a few years now, at the Alzheimer Europe conference, a large-scale study on post-diagnostic support across Europe, I'm not sure if it was only Europe or even beyond, to identify what is considered post-diagnostic support and what is being offered. And they concluded in their talk that post-diagnostic support provision varied considerably, and that in some cases it was not even a distinct service. So just to give a few examples of what was presented in Germany and Finland, if they're talking about post-diagnostic support, they're talking about public providers that can provide information on dementia, counseling and peer support. In Ireland and Wales, they are more talking about key workers who mostly focus on the coordination of care and services surrounding dementia. In Greece, there is a regional person or service that supports the person with dementia, whereas in Israel, they're more talking about a proactive approach where they draft a care plan immediately following the diagnosis. So at that time, it was already identified to vary considerably across countries. If we then look more recently at the World Alzheimer Report in 2022, I'm just zooming in on a few numbers that are relevant for the topic of today. I find it quite astonishing that, well, depending on whether you're from a low income or high income country, 37 to 45% of people are offered no support after the diagnosis. 66% of the people reported to have no personalized or person-centered care plan, and more than half of the carers indicated to be stressed often or even all the time. And so the advice based on this report was that governments must build robust models of post-diagnostic support that are being tested, funded, monitored, and fine-tuned, where person-centered care must become the norm, and support for carers must be prioritized as the individual second patient they're often referred to. Now I would like to zoom in on some specific studies. Some of you might be familiar with the Angela project, which is a large-scale project in the UK on young onset dementia. And they performed a national survey on services available for people with young onset dementia. Quite a few people that participated, over 200. And I think the findings from this study were very relevant, but again, I would like to zoom in on some of the numbers that I thought were relevant for what we're talking about today. And I think in line with the Alzheimer, the World Alzheimer Report, the numbers show that, in this case, it differed on whether you were seen at a specialized center for young onset dementia or a general neurology clinic, or even some people who are only seen by their GP during the diagnostic trajectory. So the numbers differed between these cases, but approximately 40% indicated to have no follow-up in the first 6 weeks after diagnosis, and almost 40% reported seeing no healthcare professional within the past 3 months. A third reported having no routine follow-up appointments, and only 38% indicated to have support from a case manager or key worker. So in the Netherlands, we refer to this as a case manager, so the person who coordinates the care surrounding the person with dementia. But I understood from my colleague that actually in the UK, this is often referred to as a key worker. So during my presentation, I use both terms. So this is on the showing, you know, that the support that is available can be improved. And now I would like to zoom in on a few studies reporting lived experiences. So what are actually the needs and wishes of the people with dementia and their families during the diagnostic trajectory. And for this, I would first like to go back to 2015, a Dutch study performed by Boot et al., in which they described the so-called early stage need paradox. So they actually identified that carers in the more progressed stages of the trajectory looked back at the early stages and actually indicated that if they, they stressed that if they would have received care and support early on in the process, that would have facilitated their acceptance process. But actually early carers that were in the early stages actually indicated that they find it difficult to accept help because they do not want to stigmatize their situation or do not want to be seen as in need of assistance or help. And so actually in this study, they identify barriers and facilitators in this acceptance process. And they identified that a lack of knowledge can be a barrier on dementia and what dementia is. A focus on loss and a difficulty acknowledging that the situation or your relationship is changing. And facilitators were a better understanding of the disease, increased personal time, structuring one's day, and also using appropriate humor. So Boats and all and colleagues concluded that early therapeutic interventions could help caregivers identify their needs, increase knowledge about changes in their roles and also in their relationship, and focus on enhancement of the positive intact experiences in order to prevent caregiver burden. So already at this stage, at this point in time, there was a clear need for this support early on. Another study in Italy, where they did interviews with spouses and adult children, identified three themes during the diagnostic trajectory. So problems around diagnosis, and then I would like to zoom in on the sub-theme of inappropriate communication. So actually the term young onset dementia was not clearly named, but rather vague words such as memory problems were used. And also the need for counseling that was focused on. So they didn't know anything about dementia. It was shocking how the condition would develop, what the prognosis was, and their experience was that they had to find this out all by themselves. Then actually one theme on its own is the lack of post-diagnostic support. So a lack of coordination of services. And also, of course, in case of positive experiences, people emphasize that if their neurologist or someone else during the diagnostic trajectory took the time to tell them more and give them information on the diagnosis and how it would develop, that was seen as a positive thing. Another study from the US also identified, their experiences with providers, and they divided it in negative experience and positive experiences. I don't want to go through all of these right now, but I think if you glance over them, you can see a similar theme coming up, that negative experiences were mostly in line with the idea that, people were given the diagnosis and no extra information or little information was given. So it was really like, okay, you have this diagnosis and now, that's it. Whereas in case they were given the time and effort and explanations on what it means, what the disease is, what the symptoms are, and where to go to for support, that was seen as a positive experience. So again, stressing the need for this support early on. Then lastly, another study from the Angela project actually in the UK actually identified, I think, some relevant statements during the different phases of the diagnostic process. So during the referral process, they emphasized that clinicians should really listen to the person as well as their family as a whole. So not only focusing on the person with dementia, having a single point of contact during the assessment process. Compassion and empathy and respect during the process, and providing information was seen as important. Give them enough opportunity to ask questions, to speak separately, so not at the same time, and also to have a multidisciplinary team involved in the diagnostic process to really provide the appropriate support. And then during the diagnostic process, what I found very interesting is that they also indicated that they would want to have a letter or some sort of a folder in which extra information about the diagnosis is given. So this was a very brief overview of what we find on the literature on young onset dementia regarding their experiences and the availability of post-diagnostic support. And I think it really shows that there is a need. So a lot of research has been done, and now the time is to actually come up with a solution. So this is the situation currently in the Netherlands. So this figure shows an average trajectory of someone who receives the diagnosis of dementia. So first seen by their GP, then the diagnostic process is performed at a memory clinic generally. Then they may or may not be seen irregularly by their GP, but it's only in a later stage where the case management is arranged, or other facilities such as daycare. And so actually there's this gap where people just received a diagnosis, may have a lot of questions of what this means and what will happen in the future, but there is currently no one filling this gap. Another problem, at least in the Netherlands, is that there are long waiting lists for case managers, specifically for those who are specialized in young onset dementia. And so we think that the memory clinic can actually play an important role in filling this gap. So many people have had a long trajectory in where it was unclear what was going on. As you can see in this figure, actually, this is the time where actually no formal care is arranged. And you can see this is more than double for people with young onset compared to a later onset. So there are a lot of questions and a lot of time waiting on what is the diagnosis and what does this mean. And so we think that as a memory clinic, we should fill this gap. So I would like to go into that now in more detail. So 2 years ago, we came up with the post-diagnostic support program. And the key principle is that it's proactive and structured, and it's for everyone who is newly diagnosed with dementia. And so 6 weeks after receiving diagnosis, we invite everyone to come back to our memory clinic, where they have a 60-minute appointment with a care consultant, which can be a specialized nurse or someone else with experience with people with young onset dementia. And so before, we're now actually just implementing it as standard care for everyone, but in the beginning, we also wanted to do research into the effectiveness. So we wanted to measure, does it actually lead to more knowledge about dementia, more knowledge about dementia care and facilities, and also help cope the caregiver better. And so we follow the 5-pillar post-diagnostic support model of Alzheimer's Scotland, which you can see here, which is really a framework provided for people living with dementia and their families, to provide them with the tools and connections, resources and plans to live as well as possible with dementia and prepare for the future. So the first part of the appointment is really focused on providing education about the disease, the symptoms, and their management. So really explaining that dementia is an overarching name for multiple diseases, and then a personalized explanation of what their specific diagnosis is. So do they have Alzheimer's disease? Do they have frontotemporal dementia, Lewy body dementia, and really explain what the accompanying symptoms and prognosis of these diseases are. The care consultant is also instructed to beforehand read into the neuropsychological profile. So during the diagnostic process, all patients perform a neuropsychological assessment, and there's a report drawn up. And so we ask the care consultant to really read into the cognitive and behavioral profile of the specific patient, so they can offer personalized coaching in how to deal with these symptoms in daily life. And why are we emphasizing this? Is because there's increasing evidence for the presence of neuropsychiatric symptoms in the early stages of dementia. So often it is thought that it's only in the progressed stages, but as you can see in the figure here, people with mild cognitive impairment, I think almost 80% experience at least one neuropsychiatric symptom. And although we know for the different forms of dementia that specific neuropsychiatric symptoms are more common. So for example, with FTD, we often see the disinhibition, the changes in eating behavior and the compulsive behaviors. And with Lewy body dementia, the hallucinations and delusions, but there's actually also quite a lot of overlap. And what makes it even more complicated is that there are a lot of differences in how it presents itself and how the trajectory is. So that differs even between people with the same form of dementia. But what we do know is that it impacts nearly every patient with dementia during the care trajectory at some point. And so we performed a large study, the BEAT study, to investigate the prevalence and treatment of these symptoms. And the reason why it's so difficult to recognize and why it's so different between individuals is that there are many factors that play a part in what neuropsychiatric symptoms show themselves and at what stage. So for example, there are the environmental factors, over or under stimulation, someone's structure and daily routines, but also their personality and coping style. Is there a prior history of psychiatry? Medical problems or discomfort, such as pain, sleeping problems, they can all play a part. And then there are the characteristics of the caregiver. How stressed is the caregiver? Depression or fatigue can play a part. Their knowledge about dementia, their communication style. And then there are, of course, the consequences of dementia itself. So the brain damage and the accompanying cognitive problems. And these factors all contribute to neuropsychiatric problems in dementia. And what we know is that the consequences are big because it leads to increased caregiver burden, a decreased quality of life, and also a faster disease progression. And currently, this is often medication targeted, but there is actually little evidence for the effectiveness of these medications. And we do know that they have serious side effects. So guidelines really recommend non-pharmacological treatments at the moment, but these are not specific and currently often targeted at people in the progressed stages of dementia and populations who are living in a nursing home, whereas we believe that it actually can help people to stay longer at home if we target these symptoms early on in the trajectory. Well, the second theme during the appointment is education on available dementia care and services. So what is a case manager? What can you expect? What are the facilities that are available in the country, but also regional? And we really here want to also promote a proactive approach. So like I said earlier on, or what I showed, the early need stage paradox, where people at first say, well, just leave us for now. We need to process this. We need to process this first, and everything is okay for now. We really want to promote to already start thinking about these arrangements early on, also because it allows to discuss it with the person living with dementia and ask for what their wishes would be later on in the disease stage. So really also to think about advanced care planning with the GP and a future key worker. And then the last theme to be addressed is the support for the caregiver. So really also promote involving their network early on. So family and friends, we often see that people are reluctant to do that because they don't want to ask for help. But we really want to promote maintaining time for self and their own social network, and also address the changes in the spousal relationship. So recently, colleagues and I wrote an article, which was actually a commentary on another article that showed that the quality of the relationship in people with young onset dementia changes after receiving the diagnosis. And we actually think that this should also be targeted early on in the post-diagnostic support program. And then lastly, practical issues are addressed during this appointment. For example, how the driving test is arranged in the Netherlands.
Jackie, 1 minute?
Yes.
1 minute.
Yeah, oh, sorry. Yeah, I have 2 more slides, so perfect timing. So basically, what I showed earlier on the gap that is currently in the diagnostic trajectory, we think that as a memory clinic, we can fill this gap by offering post-diagnostic support, which I just outlined. So we did a small pilot a year and a half ago across the Department of Neurology and Geriatrics. So that was not specifically focused on young onset dementia yet. We did a pre and a post measurement with questionnaires targeting the different themes that I just discussed. So knowledge of dementia, knowledge of care and services. We also wanted to see whether it actually leads to an increased use of these services and the support for, well, the feeling that the carer had in support and confidence. And we found that actually by implementing this program, all scores on the questionnaires increased. And now I probably don't have to tell this audience, but you all know that young onset dementia is very different from late onset in many aspects, but not to say the time to diagnosis is often longer. The living situation is quite different from people who are usually retired to people who are working, have relatively young children. We see more atypical forms with different disease progressions and also different clinical presentations. So more neuropsychiatric symptoms. And so the needs of the caregivers are also quite different. And so in a large consortium in the Netherlands, we are now performing research on young onset dementia. All the Alzheimer's centers are involved, but also other partners. And actually a PhD student from our Alzheimer's center is now doing a project in which he is actually looking at, well, what are the earliest symptoms? Can we develop personalized patient profiles? So really also involving the system, not only the cognitive or biological aspects, but also really what is the living situation, what is the support that's available, gain an overview of available services in the Netherlands, and all these projects together should lead to a framework for person-centered post-diagnostic care and support for young onset dementia in the period immediately after the diagnosis. I would briefly like to thank everyone who was involved, and of course the people living with dementia and their families by participating in all the different research projects and sharing their experiences with us. Thank you for your attention.
Thank you so much, Jackie. That was really very full of information, and people are asking for the presentation, and we will definitely share that after in the follow-up email. If Romana could join us too, please. Lovely.
Technical difficulties, my apologies.
No problem. Thank you so much. Thank you. So that was a great presentation from Jackie. I'm going to ask Romana and Harry now. Well, thank you first of all for being prepared to contribute as panelists to this. May I ask you to introduce yourselves and offer just a brief context of your own service and talk from your own experience about what you find most important during the diagnostic process. And then I'll ask for comments on 1 or 2 other points. Romana.
Sure. Yeah, thank you very much. Sorry about that slight delay. So my name's Romana Chowdhury. I'm a neurology consultant in Leeds. So I'll just give you a little bit of an overview of what our service is and just a few points that have come to mind. And thanks very much for inviting me and everyone that's taking part today. So I run a cognitive neurology service. So I see adults from anywhere in the country with cognitive symptoms. It's primarily a diagnostic clinic. And we recently had a look at who we see. So we tend to see younger people. So the mean age is 58. About a third of those people eventually have a diagnosis of Alzheimer's, and followed by that FTD. And then other diagnoses include things like cognitive problems in the context of other neurological conditions like MS and epilepsy, or functional cognitive problems or subjective cognitive symptoms. So I was just asked to sort of have a little think about what I think is most important in the diagnostic and support process. So just taking the diagnostic side. So for me, that's very much this idea of having a multidisciplinary approach, because young onset dementia, as you all know, can present in different ways. People have often had various delays along the way before they come to see you. And so as a neurologist, because we already link in with other things like radiology, genetics, psychology, I found that those sorts of relationships with other specialties are probably most important actually in our cognitive clinics. And the other reason it's very apparent to me is that I also do a joint clinic with the memory clinic services. So anyone who's in the UK will know that most people with cognitive problems will present to a memory clinic, which are usually run by mental health services or other services as well, but not really run by neurologists. So in our joint clinic, that means both myself and a consultant psychiatrist are able to see someone together. And I think just from the feedback we have from people that we see, I think people appreciate sort of seeing the working process and the diagnostic process, and also I think being able to be a bit more concrete about next steps in diagnosis. So, if we feel confident to give a diagnosis, we can there and then, and we will, and we'll introduce the post-diagnostic support team at the same time. But if not, if we think we need other biomarker tests or something else to give a bit more certainty, then because of my multidisciplinary working, it means I could say to someone, next week I will be able to review your scan, and then the week after I will get back to you, rather than this kind of in a few months' time we'll do something. So I think the feedback we get from people is that the delays in the diagnosis, part of that is just not knowing how long the delay is. Whereas if you're able to be a bit more concrete about that, I think that can be helpful. And then I suppose the final thing to say in terms of support. So Leeds have a very good sort of post-diagnostic support team, and obviously that transition from diagnosis to support isn't a linear one. It's very individual and quite dynamic, and so being able to do joint clinics with other people present at the same time is helpful, because you can gauge how much information to give and when to give it. And again, because I see people from different parts of the country, I think we all know that memory clinic services are very variable. So there's lots of really excellent young onset specialist memory clinics in the UK, but there's lots of places where people don't specialize in young onset dementia. So even if I make a diagnosis, there is then no local post-diagnostic support to refer back to, or no sort of specific tailored information for that individual. It's more just generic information, which isn't always helpful. So again, this sort of joint working approach, I think, helps to mitigate that a bit. And then obviously there's all the things about working together and thinking about treatment and new drugs, but that's a talk for another time, I think. So I hope that's a helpful sort of insight into what I do.
Thank you, Romana. And it is that improving the support everywhere, really, in England, that the Young Dementia Network in particular is really keen to do with Dementia UK and other organisations, really keen to improve that so that everybody has access to good support. Harrow, would you be able to tell us briefly about your service and what you would identify as really important in the process?
Of course. Thank you first for the invitation. My name is Harrow Seler. I'm a cognitive neurologist at the Alzheimer's Center Erasmus MC, the same as where Jackie works. We have a large cognitive center, and we have our neurology department, who are seeing mainly the young onset dementia patients, and that's arbitrary, younger than 70 or 65 in some other centers. And we work with the geriatricians, who mainly see patients above the 70. My first job is to take care of the diagnostic process, as I think the same as Romana just told us, of patients with possible young onset dementia. As said, it's often patients and their family already had a long journey for a correct diagnosis, and it can be several delays already at the general practitioner who does not recognize it, because it's still quite rare. And we see it a lot, but for general practitioners, it's still a rare disease. So hopefully we can get a lot of information to them, that they are aware of this. But also, they've been seen by several specialists before they end up at a specialized memory clinic. I also saw it's already in the chat. We try to make a clear diagnosis as soon as possible, but sometimes it takes time for a correct diagnosis. And that's also, I think, one of the problems with post-diagnostic care. You want to give them a lot of information, but sometimes it's unclear what is the diagnosis. And then that's frustrating for patients, caregivers, but also for the doctors, I can assure you. Thankfully, at our center, we've got a multidisciplinary team to discuss all the patients with neurologists, geriatricians, neuropsychologists, radiologists, psychiatrists, dementia nurse. So we are with a team to make, well, first a clear diagnosis. I think there it starts there, but also make a plan for the actually the near future. The main problem I see, because I see a lot of second opinions from the whole Netherlands, is that it's the lack of information. So they say they make a correct diagnosis, for example, FTD, frontotemporal dementia, but no information like what kind of symptoms can they have, or will they probably develop? What is the cause of the disease? What kind of help do I need? And that's actually, in my opinion, what most of the people need. And give as also what Romana said, as tailored information as possible. And also, like I said, it's important to also acknowledge what kind of behavior is part of the disease. For example, the behavior problems in FTD, it's the disease, it's not the person, it's the disease which causes some symptoms, but also, for example, apathy in Alzheimer's disease is something what we often see, but is not always recognized as part of the disease. And that will help caregivers and family members to understand what is happening and why it's happening. I think that's also important. Thankfully in Holland we have what we call case managers, so they help patients and their families with care around dementia, and we also have some of them are specialized in young onset dementia, although in some regions there's a long waiting list. But I think it's very important to point out also for the doctors that it's available, because also as Jackie mentioned earlier, there's sometimes what we call a caregiver need paradox, where they don't need, or maybe they think they don't need any help or information, but in the end they will end up ringing our center like 1 year or sometimes 2 or 3 years later, I need help now. And to avoid that, I think it's very important to spend time early in the diagnosis about informing the caregivers why it's sensible to also to accept help in the beginning, and it shouldn't be every day, but a few times a year, but also on advanced care planning. Furthermore, in my work, I'm also available for consultation for other centers, also regarding the management of patients with FTD, pharmacological or non-pharmacological. And my research, I do a lot of research, but it's focused on the frontotemporal dementia and especially also on genetic FTD. And that's also something part of my consultations is to tell or inform about, is it genetic or not, young onset dementia. Sometimes it is, sometimes it is not, but it needs some also some tailored information to tell more about that. That's what I would like to tell about my work.
Thank you. I'm going to just pose something for you to reflect on briefly. The problems and issues identified in the different studies, UK, Italy, US, and such like, can you reflect on possible solutions that might be low-hanging fruit solutions that would improve the experience of the person and their family, but maybe more straightforward to bring into play. We're all keen to improve the situation for people. Romana, have you any thoughts on that low-hanging fruit?
Yeah, it's a good question. I think part of it is raising awareness around what services are available in different areas for young onset dementia. So I think the surprising thing for me as a neurologist was I didn't really realise when I started working that there were different services for older and younger onset dementia, for example. And so I think just some, even something very simple like a registry, just showing, where are services, who do they see, who is the point of contact. And I think Harrow and Jackie raised this really good point of having a point of contact throughout the process. So again, I'd often thought of it as once a diagnosis has been made, and that's when that sort of support begins. But an actually very obvious thing to do is to have that from your first encounter with somebody, a named person. And again, I think that's I don't see why that can't be easily implemented and done. So I think that sort of sharing of information and ways for people to keep track of what is going on is going to help a bit, because there are going to be delays for some people. It's just inevitable, the way that services are, and also that it's just difficult to diagnose sometimes, and access to different types of scans and biomarkers and things like that varies. So I think
keeping in touch.
A point of contact and just knowing what there is in your local area.
Thank you. Harrow, have you got anything to add on that low-hanging fruit?
Yeah, I think it's a lot about information and the repetition of information. So first, what I think the doctors are used to are to tell the diagnosis and tell a lot in the same appointment, and they get a lot of information, and it needs to sink in, and that's the reason why we now also have that 6-week period. It can be 4 weeks, can be 8 weeks, but to come back again. And people have a lot of questions, and that it can sink in, and it can be with the doctor or with a nurse, with a dementia nurse. I think that doesn't matter, but it's an opportunity to give a repetition of information. I think that's crucial in these in young onset, or in dementia in general, but also in young onset dementia.
Yes, that's a really good point. Some of these things just could be done, couldn't they? And they would be so helpful for people, that point of contact, the repetition of the information. And let's move to, I'm sorry, we're going to need to move to questions now, because I'm really keen to allow time for that. First up, use of memantine for frontotemporal dementia and young onset dementia Alzheimer's. What would your recommendation be? And Harrow, you've opted to answer this one. Thank you.
Yeah, for FTD, the answer is short. It's no. There's no rule for it. It's not proven, and maybe it's even working oppositely. It's the opposite working. In early onset, there are mixed results. There's a lot of combination with, for example, the choline esterase inhibitors. But the effect is not really large. So it's not a no, but it can be tried. I'm not sure whether Romana will use it in AD patients in general, memantine, but it's something we try, but it's not always, it's not always effective. It's sometimes a bit of trial and error, to keep it very simple. Yeah.
Right. Romana, did you want to add anything?
The same. So I don't use it in FTD, but we do try it in Alzheimer's with mixed results.
Okay, thank you for that. We have somebody from the Oldham area pointing out that there's nobody else from the Oldham area on the webinar, and so I'm going to suggest to that person that they share the Young Dementia Network site and news with as many people they can in that particular area, and encourage them to sign up, and then they'll know all about the activities of the network. And really encourage you, as you suggested, to share it with your local support in the in the local hospice. So please do that. Recommend anyone does that. Then we have person diagnosed at the age of 63, now 67, still classed. Is he still classed as young onset dementia? Just expressing the fact that the person didn't know there was any such thing as young onset dementia. So we've got such a job to do in raising the profile, haven't we? So Harrow, you had a response to that. I know there's an acceptance now around what young onset dementia is.
Well, it's also, if you look at more research wise, it can be sometimes under 70 or under 65. But also, the most important thing is the practical way of looking for help. And like in Holland, where, like we said, we've got case managers, but that's sometimes quite strictly if you're at the time of, well, asking for help. So now 67, you can be 65 plus, and then you are not in the young onset dementia. But often in my experience, we can explain to case managers why someone that started at a young onset, and it depends also on what kind of groups they can be for. We also have daycare in the Netherlands. Sometimes someone is 67, but feels like 50, but also opposite. Someone of 67 can feel or looks like someone of 80. So that's something you have, in my opinion, you have to look in more detail at. On personal level, but it's not always possible in every region.
Yeah. Romana, did you want to add anything?
Yeah, I mean, I guess it's a bit of both. So sometimes it just seemed a bit arbitrary. So the 65 is the cutoff that's used. When we're looking at eligibility for genetic tests for dementia, then 55 is the age that's used. But often just ignore these criteria and really go on an individual basis. But yeah, definitely in terms of accessing other support and groups, I think maybe 63 versus 65 isn't hugely different, but it could be if you're working versus retired, and it's, the ages of your children, that 2 years apart can be very different. So, you do need specialized services, I think, that take into account people who do have a younger age of onset.
We're trying to press home that young onset is symptoms emerging under the age of 65, because that's the international consensus right now, isn't it? And that flexibility is required, isn't it? Because you can be living with the impact of young onset dementia into your late 60s, and still be living with the fact that you haven't been able to pay off your mortgage or build a pension or see your children through university, or all of those very, very different circumstances that and you may still be in work at 67 too. I'm not sure what the retirement age is in the Netherlands, but it's being pushed up and up in the UK.
Also in the Netherlands, yeah.
Yes, also in the Netherlands, yes. Just passing back to Jackie, amazing presentation. That's popped up in the question, but there's lots and lots of praise for the presentation in the chat, which you'll be able to pick up later. Thank you for that. This is one for Jackie. We're trying to evaluate the post-diagnostic support we provide. Are you able to share the questionnaires that you used in your evaluations, please? Is that possible?
Yeah, definitely. Of course, they are in Dutch, but we can we can try and look into if we can, because they're not long. They're 4 simple questionnaires. I think we can see if we can get them translated rather easily and send them. Shall we share them with you and Catherine?
Yes, share them with Catherine, and then we'll make note of the individual who'd like them.
Yeah. And
Thank
I can see
so
that there are
much,
quite a few suggestions for the slides if they're going to be shared, but I think they are.
Yes.
Yes.
Someone would like to offer the presentation to their government. I'm not sure which government it is, but yes, because it's a much needed research, much needed evidence, much needed improvement of the whole process. So, oh, I've lost there. We have time for a couple more. So presumably that would be fine, would it?
Yes, yeah,
Yes.
I mean the webinar is freely available, right? So it's to share with who you wanted to share it with.
Yeah. Does anyone recognize the difficulty in the diagnostic phase of young onset dementia, that the person with symptoms doesn't want or doesn't see the need to go to the GP, but the relatives do and do need the support? The relatives can't get any support until the diagnosis is made. Any suggestions on how to solve this? That's a tricky one, isn't it? Quite common, I think, as well. Anyone like to?
It's a very big problem. We see it often in frontotemporal dementia, because the problem is they don't have any complaints, the patients. So why should they go to a doctor? Because they are fine. Sometimes it helps. It sounds a bit stupid maybe, but that they go to the GP to prove that the family is wrong. So to invert it, so not that something is wrong, but to make sure they are okay, or that the family is wrong. Sometimes that helps to create, some space. Sometimes, but that's in the Netherlands, there are doctors, I'm not sure how to call it in English, but they can, it's not the GP, but they can visit at home. So they can have a look what is going on there at home, do a bit of testing, but testing is always hard because they don't want to do that. But to get an overview what is happening at people's house. Sometimes it's so obvious there's a dementia that then there can be a diagnosis and help can be started, even without visiting a hospital. But yeah, especially for example, as like FTD, it's really hard because it can be quite subtle, and you really want to see them and make sure that's not something else, and to have an MRI or neuropsychological testing, etc. So I think that's one of the key problems we also face, to really get them in the hospital. But yeah, my advice is to change it around, to make sure that there's nothing wrong. Not that that sometimes helps.
Yeah. And any comment from you, Romana, on that, or shall I move to another question?
Yeah, I mean, I've had people who will come to a clinic and then walk out within the first couple of minutes saying there's nothing wrong, and I'm left for 1 hour with their spouse, and I hope that's still, therapeutic, at least for the person that's come with the patient, but it can be so difficult. And again, this is where my sort of working with the memory clinics is so helpful, because people can go out and see people at home, and get a feel for what's going on. And as neurologists in a hospital, we just don't do that. So maybe that's something that we should be looking at developing as well. But yeah, it's very common.
Great, thank you for that. Right. Oh, we're on the last minute, so I think I'm really sorry we haven't covered all of the questions, so I apologize for that. But I'm going to just close the webinar now by saying that we would usually be having a webinar in May, and we're just confirming whether that we are able to do the May one, but we will let you know via the Young Dementia Network news. If you're not a member of the Young Dementia Network, join up, and then you'll know all about the events that are being run. So you'll know about the webinar, whether it's in May or not. But what will be promoted shortly is the June the 19th webinar, which Romana here is offering us to, and that this is a showcase of the Leeds Young Onset Dementia Service. So it's that working together, collaborative approach to young onset dementia, which Romana mentioned earlier in this webinar, neurology and psychiatry, and connecting in with all those other different professions. So thank you very much for attending today, and thank you very much, Jackie, Harrow and Romana. Excellent webinar. Within about 48 hours, I think we'll be sending out the follow-up with the presentation and the recording. So in the meantime, thank you so much for everyone who's helped with this.
Thank you.
Thanks. Thank you.
Thank you.